Huh? You are live now. You can start talking.
Good afternoon, everyone. A very warm welcome to you all. My name is Dr. Naren Krishna. I am from Dr. Reddy's medical team. And today we are here in this symposium called Spectrum Symposium, and we have few of the eminent faculty in the field of diabetes for our today's sessions. And today we have none other than Dr. Hemraj Chandalya. Sir is senior most clinician in our country. He is the director endocrinology, diabetes and metabolism, Jaslok Hospital, Mumbai, and he is also serving as director, Denmark, that is Diabetes Endocrine Nutrition Management and Research Center. Sir has held various prestigious faculty positions, which include University of Alabama Medical Center, Birmingham, USA, and Grand Medical College, Mumbai. He has more than 75 articles to his credit, and he also has served as editor in numerous journals, which include International Journal of Diabetes in Developing Countries, Diabetes Today, and he's also served as editor-in-chief for RSSDI textbook, 2015 edition. Sir, I welcome you to today's program and hand it over to you. Over to you, sir.
Yes, thank you, Dr. Naveen. I'll just take 2 minutes to introduce today's subject and this symposium, which I think is going to be very interesting. I want to make three very important points regarding the molecule that we are going to discuss today. And one is, of course, hypoglycemia. See, sulfonylureas have been now relegated to almost like oblivion. Many times, many speakers will tell you that we don't use sulfonylureas. But let me tell you, this is far from the fact. Still, I find even UK, my patients living in London, visit Mumbai, I see they're all receiving sulfonylurea and metformin. And because this is the mainstay of treatment, it's the most cost-effective treatment. And it is still going to be on, and it continues to be on in spite of there being molecules which are now coming with some other great qualities. So we have to use appropriately all the molecules. So today we will try to place this glycoside in the right perspective from that angle. One more thing is that hypoglycemia, sulfonylurea, it is one of the important features. So they're very effective drugs, so they cause hypoglycemia. And most of them cause bad hypoglycemia. But glycoside is exception. And the subsequent speakers will tell you why. What are the different qualities of this binding with receptors, etc., which really give it this great edge in producing less and less hypoglycemia. And I have truly seen this in practice. I compared glimepiride with glycoside. Bad hypoglycemia I have seen with glimepiride. With the glycoside, I have not seen a severe hypoglycemia yet. Then other thing is sulfonylureas were branded as being injurious to cardiovascular system, which was old sulfonylureas, first and second generation, especially tolbutamide was studied long ago, and then the others, including glibenclamide, has certainly not shown benefit. Maybe some injurious effect. But glimepiride and glycoside have been shown now not by direct studies which are comparable to CV outcome trials being conducted in the modern time, but by very, very extensive meta-analysis and all, that there are cardiovascular benefits, and they're part of some study like advanced studies clearly showed that there are cardiovascular benefits occur, and even some renal benefit occur with glycoside. So this is CV benefit is a big issue now. So this molecule we see from that angle. Another very practical tip I want to give you. You have a difficult to control type 2 diabetic. Can you introduce all oral agents and insulin? You give metformin for sensitizing 3 times a day, give insulin, basal bolus, 4 doses a day, and you don't find control. I'll give you a clue what I do when some of you do this and patients land up with me with 8 or 10 with 10% A1C. I use glycoside, the plain glycoside, 40 to 80 milligram 3 times a day with metformin, and these combinations are enough in our country. You see, and sometimes I use 20 milligram TDS with half of 40 milligram, 540 half TDS. Hence, the sensitizing effect of sulfonylurea we have forgotten. It's not being talked about. Your metformin or recognized sensitizing, then pioglitazone sensitizing, DPP4 we say also when you lower sugar you sensitize, SGLT2 sensitize, But sulfonylureas were the first sensitizing agents described in the literature, diabetology literature. You will not be able to access that, and many of you have not seen that literature. There are hundreds of papers on it because this occurred around in 1975, 80s. And your databases don't go back beyond journal of 15 years. With difficulty, you can reach journal which is published 30 years back. But this is very good scientific evidence, and I've seen their superb sensitizing agents. But only thing is you invite hypoglycemia when you use with insulin. So that's why there I use glycoside exclusively, and I find I get away without hypoglycemia and getting superb sensitizing effect. So I just gave you these three instances why, I'm particularly fond of this molecule. I frankly use it extensively, and I'm happy I'm involved in this symposium and with the very able speakers. So with this introduction, my subsequent faculty is going to truly elaborate on some of these points which I mentioned to you. See, and with that, I would like to go further with the first talk by Dr. Vijay Niglur. Let me introduce Dr. Vijay Niglur. Dr. Vijay Niglur is a very eminent diabetologist and very active academician in diabetology. See, he has got his own center running beautifully in Dombivli, see, and Thane, and he attached to Jupiter Hospital. You see, and many current positions. He's teaching College of Physicians, Surgeons, teaching Public Health Foundation of India. He conducted many courses for Public Health Foundation of India. So nice courses, you see, and of course, I think he runs a lot of educational programs, patient education in a very active way, and he has been involved with RSSDI also in a big way. And he is one who attends a lot of medical meetings. You see, he takes pains to travel. Only COVID period he stuck here, but then he reads avidly, and he will give you the latest information very well up to date. So I invite Dr. Vijay Neglur, and I must say that very proudly that he was my resident in Grand Medical College. He and Dr. Panikar, these are two of my most notable residents who work under my, and Dr. Benny Neglur. Benny also simultaneously when Vijay was registrar, he was my house physician. So I think I had a tremendous association with him, and I was always happy to listen to him and learn something new from. Yes,
Thank,
Vijay.
thank you, sir, for your kind words of introduction. Very generous introduction. And thank you, Reddy's Lab, Dr. Krishna, for inviting me to speak on the subject of the EMR-based glycoside in a real-world analysis or real-world evidence. So what is this real-world evidence mean? It actually means the data collected during the routine practice in the real world where the patient is going in about in a daily life. Now, when did the FDA got interested in this real world? It was always interested long time ago to report the adverse events. The first initiative by the FDA of using the real world evidence is to report the adverse event way back. And then in 2007, they had what is called a Sentinel initiative, where they used the National Electronic Record System to create data. And then they also included in made EpiNet the devices as well. A lot of devices that we use for the glucose control and many of the devices for blood pressure monitoring were also brought under the purview of the real world evidence. And in 2017, the FDA real world program started with the regulation in the decision making of the drugs and device. Now, is the real world evidence is needed? Why do you need it? Because these randomized control trials are actually less desirable, expensive, and take long time, are not generalizable, and in conclusion, sometimes inconclusive, and there are a lot of strict, stringent way of including or exclusion criteria of patients, and the patients are difficult to recruit in a randomized control trial. In the real world data actually are more valuable because they have very easily accessible. We have a large database and recognition that the risk and the benefits for a population requires a real world evidence of a medical product in use. So therefore, The real world has really come in a big way, and today we're going to discuss this real world evidence for the glycoside modified release. The first paper publication by Naren Krishna, who's there today with us, on the effect of glycoside and a glycoside plus metformin in combination of glycemic control in patients with type 2 diabetes in India, a real-world retrospective longitudinal observational study. All the real-world studies, observational studies from the electronic medical records. This is the Indian real-world effectiveness of the glycoside or a glycoside metformin combination. This is a retrospective study, which is observational real-world data. The EMR source is the HealthPlex technology, PRVs. The study population, again from the EMR data of the Indian type 2 diabetic patients, and the two hemoglobin A1C readings are taken in 90 days apart. And this is the study which was conducted between January 2016 to October 2019. We had the glycolides alone and a glycoside add-on in the glycoside group. And then we had a glycoside plus metformin combination and the glycoside plus met plus additional drugs, maybe DPP-4 inhibitor or a pioglitazone and so on and so forth. So that's the methodology of the study. The study arm had, of course, two groups of A1C of more than 6.5 and A1C of more than 7. Among of the 498 patients, glycoside alone was 66. The glycoside metformin combination had 179 patients versus in the A1C more than 7% was 150, and glycoside add-on was 169 in the A1C of 6.5, and above 7 was 153. So this is the breakup of the number of people in the various combination therapy that we had. So this is how we have the patient flow, the total number of patients of more than 1 million, out of which 147,000 were on sulfonylureas and 470,000 on bigonides. And those patients prescribed only glycoside were 51,000, and patients with newly initiated glycoside only or were prescribed glycoside just 30 days prior to the study were about 4,000, and patients of baseline hemoglobin more than 6.5% at the baseline was 722, and those patients who had the A1C of 90 days later were only 66. And same thing here with the glycoside and metformin. And again, we had about 1,477 patients with the A1C of more than 6.5% and about 169 patients who could have the A1C value after 90 days as well was 169. In the group of sulfonylurea, and bigonides, here we have glycoside metformin combination. Here about 8,000 patients A1C of more than 6.5, and the metformin started less than 30 days. Again, here 4,000 patients, and A1C more than 6.5, 1,295 patients. Here 852 patients, and those patients who could have the A1C after 90 days, it was 179 patients here and 84 patients here. So this is the flow of patients. And the study endpoint was, the primary endpoint was to look at the A1C baseline after 90 days of treatment, change in the A1C after 90 days of treatment. And secondary endpoints included assessment of the dosages and formulation of the glycoside or glycoside metformin, assessment of anti-hyperglycemic agents to which glycoside or glycoside plus metformin were added as an adjunct therapy to control the hyperglycemia. So this is the group of patients who had A1C of more than 6.5%. And this is the blue bar says at the beginning of the patient study group. And that is, and the orange or the brown bar, which says at the end of 90 days of second visit, you can see the distinct change in the A1C in the 81 and 74 patients. There's difference of from 8.1 point to 7.4. Again, the glycoside metformin, the difference in the A1C is very evident here. Add on to glycoside, and of course, add on glycoside with metformin. If we look at the change in the A1C from the baseline, the effect or the highest effect was seen in people who use the combination of glycoside metformin, and that is significant so far the p-value is concerned. And the glycoside metformin add-on was also significant in terms of the A1C reduction. Glycoside alone reduced A1C by 0.62%, but of course it was not significant statistically. This between day 1 and day 2 visit, and the first and the second visit. And those people who had A1C of more than 7%, again, similar group, gliclazide alone with metformin combination and addition to gliclazide, in addition to gliclazide metformin combination. And you can see here the change in the A1C with gliclazide metformin combination was highly significant, of 1.6, and that is significant. And those patients who had add-on to gliclazide plus metformin, could be DPP-4 or pioglitazone, was also significant with reduction of 1.4. So therefore, in the both groups, where the A1C of 6.5 or 7, the gliclazide and gliclazide metformin combination did extremely well in reducing the A1C significantly with the significant p-values. If you look at again the change in A1C from the baseline, those with the A1C of 7 and those with 6.5, the reduction in gliclazide alone was 0.8 and 0.62. With the add-on, it is 1.6, 1.3, the change in the A1C. And metformin, you can see it 1.2 and 1.1. That was the change in the A1C from the baseline 7 or 6.5. And gliclazide metformin plus add-on to 1.4, 1.2. So reduction across the A1C baseline in all the study arms was quite significantly seen here. Now, if you look at the dosages and formulations of gliclazide used, the gliclazide with immediate release and the extended release. I would like to clarify a very important aspect of the immediate release and the extended release. What is the difference? The difference is when the gliclazide clears on the body from the cytochrome 450 in the mitochondria, when the drug undergoes glucuronization, that is, a lipid-soluble molecule is converted to water-soluble molecule, the pathway which is used by gliclazide is CYP2C9, whereas in the modified release or extended release gliclazide uses the another pathway of CYP2C19. And just to remind you that CYP2C9 is a common pathway. Many drugs enter here. And this is quite an unusual pathway for the extended release. That's why the drug-drug interaction is quite less with the extended release. And that's why the safety also increases extended release because of this mechanism of the excretion of drug from the body from the mitochondria in the cytochrome 450, which is called as xenobiotics, where how the body gets rid of the drug by converting a lipid-soluble molecule into a water-soluble molecule. So here again, the extended release, there were 26 patients at the baseline with A1C of 6.5 to 8%, 19 from 8.1, 10%, only 3 patients about 10% A1C, and gliclazide alone again had 37, 24, 5 respectively in this particular A1C. And the dose was 40 milligrams, 80 milligrams, and 160 milligrams was used. Again, the formulations of gliclazide metformin, immediate release and extended release, was again 82 in the 6.5 to 8 groups, 52 in 8.1 to 10, and about 10 was 45. And extended release was 30 in the 6.5 to 8, 11 in 8.1 to 10, and about 10 was 14. This is the breakup of the drugs used in different A1Cs in this particular study. So the anti-hyperglycemic agents which are added to gliclazide and metformin were, besides bigonides, DPP inhibitors, insulin, SGLT2 inhibitors, AGIs, glitazones, and other sulfonylureas were also used in this particular in the studies. So the effectiveness of gliclazide and a gliclazide metformin prescribed to the Indian patients with type 2 diabetes mellitus during the routine clinical practice in India was assessed using the electronic medical records, and gliclazide or a gliclazide plus metformin prescribed as a mono or add-on therapy during routine clinical practice effectively reduced A1C in Indian type 2 diabetic patients. Gliclazide can be an ideal choice of sulfonylurea is being considered. Now let's move on to the another study from UK, which is the again a real-world evidence of the gliclazide modified release. And this study was done by Melanie Davis and Kamlesh Khunti, and this is the comparative effectiveness of gliclazide modified release versus sitagliptin. This is a good comparison as a second-line treatment when the patient could not be controlled with metformin alone. And this was in type 2 diabetes patients. And this is about 1,986 patients and were studied for a period of 9 years. where they tried real-world effectiveness of glycoside modified release with sitagliptin. This is a retrospective study. The basic idea was to compare the safety and the efficacy of glycoside modified release versus sitagliptin in patients of type 2 diabetes. Again, it's a retrospective study where the patients were either randomized to see the patients were given either glycoside or sitagliptin in people who have A1C of more than 7%. Now, the basic primary aim of the study was to see the time taken by either the molecule to reach the A1C of 7%, less than 7%. That was the first primary objective of the study. And the secondary objective of the study was time to reach the A1C of below 6.5% and or the reduction of A1C more than 1%. So what's the time taken for that? That was the second objective or secondary objective of the study. Along with that, they looked also at the persistence of treatment and the durability of the glycemic control, because quite often, as Sir was saying, that sulfonylureas are blamed to exhaust the beta cells. This was again another important objective, to look for the sustainability or durability of the study. And of course, the adherence is the most important part of the therapy in diabetes, where Jennifer Liponsky looked at the people of diabetes of 145,000 and plus, and found out that 25% of the patients who bought the medicine did not take it all. And remaining patients stopped the medication at the end of 1 year. 50% of the patients stopped the medication at the 1 year, in 1 year. That's how the adherence of therapy is very important. And here we had again seen how much is adherence in this patient. So this study was carried on and also looked at the hypoglycemic events. So durational study was 9 years from 1st January 10 to 2010 to 19. And the patients were matched 1:1, which is called a high dimensional propensity score matching. This is the kind of a real world analysis you do to see the probability, because ultimately the propensity score matching tells you in terms of probability. So the answer can be 0% or 100%. That is how the probability works. You know, unlike in Sholay, the Sikka which Amitabh Bachchan carried, both sides it was head. So therefore the probability was 100%, because whichever way you toss, it was 100%. But here they tried to see what is the high dimensional. They tried to match a lot of covariates to find out what is the best outcome of this particular trial. So this is how the flow of the patient began. 45,000 patients with the index drug from Jan 2010 to 19. More than 18 years of the index drug is used, and more than 1 year up to the standard practice. And then these patients totally were 10,000 were eligible, out of which there is missing data. So finally it was 6,000 and odd patients, and the glycoside was 1207 and 5,000 and odd patients sitagliptin. And when you have to match 1:1 propensity score match, eventually it was 993 patients in each arm which was studied, either glycoside MR or sitagliptin. Here again, we look at the probability of patient getting the A1C below 7%. This is a primary outcome. And you can see the dark line is that of glycoside modified release, and the light line is that of sitagliptin. And what you see here is that 35% there's an increased chance of glycoside getting the target of below 7%. And the second part, which is important and obvious in here, it took just 3 months. Within 3 months, you could get the A1C below 7%, unlike sitagliptin took a little longer time. And then if you look at the durability of the study, it was more than 2.5 years. So what was thought earlier, that the sulfonylurea exhausts beta cell, this hypothesis kept to rest by saying that there's a good durability of the study, both with sitagliptin and glycoside MR. Secondary objective or secondary outcome of A1C of less than 6.5%, there is a 51% more chance of glycoside getting that A1C compared to sitagliptin. So efficacy-wise, glycoside scores over sitagliptin in terms of efficacy, and the durability are also equal in both the arms. And thirdly, the third objective was to look at the reduction of more than 1% of the A1C. And here again, there was 11% extra chance or extra probability of the glycoside modified release getting the target of A1C compared to sitagliptin, which was definitely less effective. And also the hypoglycemia, which is not mentioned in this particular slide, there were totally 15 patients of hypoglycemia, which was seen in patients of glycoside MR, out of which 4 were little severe, would require assistance, and 11 did not require assistance, they could manage on their own, which makes it 4.7 per 1,000 patient years. And if we look at sitagliptin, there were only 8 patients reported, out of which 1 patient had a severe hypoglycemia, 7 did not have, which makes it 2.6 patient year per 1,000 patient years, which again means that the numerically glycoside had a more amount of hypoglycemia, which is expected, but then the number of severe events were quite less, and most of the patients could manage their hypoglycemia effectively on their own without needing assistance. Only 4 patients needed assistance. The others did not need assistance. And sitagliptin arm also had history of hypoglycemia, and 1 was severe, and the remaining were not severe. So to conclude what I said so far in the last 15 minutes, that rapid reduction of A1C levels can help to prevent a long-term risk of complication. And early achievement of a glycemic control has been associated with better long-term outcome, which was called the legacy effect. The legacy effect was actually described for metformin, but it can be used for any drug when you have a good glycemic control and reduce the glycemic burden, and therefore give the benefit of micro and macrovascular complication. So that is called legacy effect. Leah Triprong, this chap is from Chicago, who looked at the studies of patients where the A1C of more than 6.5% during the first year of treatment, means higher than 6.5%, and the patients were given treatment. And this is study published in last year in the Diabetes Care, where they saw the A1C remained above 6.5% during the first year of treatment with higher risk of micro and macrovascular complications. I'm again emphasizing more than 6.5% in the first year of treatment had 20% increased macrovascular event. This is also published by Kamlesh Khunti, who also has a similar data of 20% increased macrovascular events. And again, more than 40% of microvascular event. If the patient remained above 6.5 in the first year of treatment after having been diagnosed with diabetes, and with those more than 7% during the first year had still higher mortality than about 6.5%. So it adds to say that when we get the control within 3 months after you start glycoside, and effectively you can get more than 35% chance of getting A1C controlled within 3 months by glycoside, will certainly prevent both the micro and the macrovascular event. Needless to emphasize that point, but it's quite clear. So glycoside MR led to greater probability of patient achieving glycemic targets compared to DPP4, sitagliptin in the study which I mentioned earlier. So with that, I end my talk. Thank you very much for the patient listening. Over to sir.
Chandalya sir, you're on mute.
I know. Okay, I'm okay now. Yeah.
Yes, yes,
Yeah.
sir.
Now we move on to the next talk, and of course we'll be discussing what Dr. Panigar presented and the next speaker presented at the panel discussion. Our next speaker is Dr. Suri. Dr. Suri is from Sandeep Suri. He is a senior diabetologist at the Advanced Diabetes and Critical Care at Hisar, Haryana, and he's president of Indian Podiatry Association. So Dr. Sandeep Suri will take the subject further, navigating type 2 diabetes patients safely towards euglycemia with glycoside. So he's going to give you the clinical use of glycoside and positioning it safely and using it safely. So Dr. Suri.
Yeah, good evening, friends.
Yeah.
And today evening, I'm feeling extreme pleasure to be part of this academic feast. It's really a blessing for me to give my deliberations after my extremely learned senior colleague, Dr. Naglur. and a matter of great pride for me that today I'm going to share my views in front of Doyen of Diabetology, Professor Chandelia sir, who has been always been a role model, and a great teacher for all of us. And I thank Dr. Reddy for team for this for today's honor. So I'm going to share my screen. Uh, Let me have my slides. So we know that from our basics of diabetology practice and management, that it revolves around ABC. That means A is A1C control, B is blood pressure control, and C is cholesterol or dyslipidemia control. And for A1C, or you can say the glycemia control, we have a more comprehensive term nowadays, that is euglycemia, which means that uh, blood sugar should be between 70 milligram as the lowest limit and 180 milligram as the maximum limit. Beyond 180, we call it hyperglycemia, and below 70 milligram, we call it hypoglycemia. And in a non-diabetic patient who is not having diabetes and is a euglycemic, this euglycemia is maintained by a fine tuning of two hormones, that is insulin and glucagon. And this fine tuning is lost in type 2 diabetic patient, where we have inappropriately low insulin secretion and action, and also inappropriately high glucagon secretion, leading to persistent hyperglycemia. Now, recently, the range of normoglycemia and euglycemia has been further characterized as a glycemic variability from the CGMS and ambulatory glucose profile data. And the goal of type 2 diabetes management is to attain close to the state of euglycemia as safely as possible, avoiding both hyperglycemia and also hypoglycemia. And that is to avoid both acute or chronic complications of diabetes. Now we have 12 classes of drugs for management of hyperglycemia, and if we include all oral anti-diabetic drug and insulin injectables also, still we have metformin that remains as a backbone of our type 2 diabetes management. And each and every protocols and each and every guidelines, whether you are taking national guidelines or international guidelines, they endorse metformin as a first line drug. Now, to have a first add-on to metformin, we have to juggle between SGLT2 inhibitors, because they are the flavor of today's world, DPP4 inhibitors, or SUs. And here comes the role of individualization, patient-centered approach, patient-oriented approach, and we have to pick and choose the molecule as per the patient's glucophenotype, as many guidelines, national and international guidelines, they have advocated, and RSDA wheel has been there. So you have to pick and choose the drugs and make it a fully patient-centered and individualized approach. So no single size fits each and everybody. So today we are going to focus on sulfonylureas, which are basically the most commonly prescribed first add-on to metformin in the world over, especially in Southeast Asian countries and developing countries. And sulfonylureas has been a part of all national and international guidelines. Recently, also UK NICE and also Dutch type 2 diabetes management guidelines specifically advised glycoside as a preferred first add-on instead of sulfonylureas as a class, meaning that there is a different, these are the different molecules in the same class, as you have seen in bigonides, as you have seen in TZDs, as you are seeing in AGIs, as you are seeing in now SGLT2 inhibitors, and similarly like DPP4 and GLP1 and all. So there are the different molecules in the same class. Moreover, the WHO has included glycoside in along with metformin and insulin as a essential drugs, essential medicine in 2013. And looking at the safety data of glycoside in elderly population, specifically over 60-year-old age, and we do have fixed dose combination of glycoside with metformin, and this is effective, safe, and convenience dose due to OD dosing. So these are the all benefit of glycoside, and most of the guidelines and most of the researchers now picking up that glycoside is somewhat different sulfonylureas in comparison. It is the standout sulfonylureas in the whole class of sulfonylurea. So there is a classification also for sulfonylureas. It is hierarchy based classification, and also it is time action profile based classification, where long acting sulfonylureas like glibenclamide, glimepiride, glipizide modified release, and glycoside modified release has been put as a long acting agent. But to have a more functional and structural basis of sulfonylureas classification, they should be classified as sulfonylureas receptor specific like glycoside, partially specific like glimepiride, non-specific like glibenclamide and glipizide. So this is much more functional and much more structural based classification, which is much more relevant clinically also. And it all depends upon the affinity of sulfonylureas molecule binding to its receptors and its affinity towards the receptors. Now let's see whether using glycoside, whether we are using with this glycoside modified release, whether it navigates towards achieving euglycemia in our patients. So first look at the efficacy of the drug, which was never a doubt. Actually, it was never a doubt with sulfonylureas. We know that the sulfonylureas are very potent, very efficacious, potent molecules, decreasing glycemia with a very rapid onset of action right from the word go. And A1C decrease has been reported between up to the tune of 0.8 to 1.2%. And here has been a meta-analysis of 299 studies which are there in front of you. And it included more than 1 lakh patients, indicating glycoside has a superior A1C reduction than glimepiride, and even better than your DPP4 inhibitors and also your SGLT2 inhibitors. So this molecule scores apart from other oral antidiabetic drugs. Also, there is an incremental efficacy with up titration of glycoside modified release dose when you move from 30 milligram to 120 milligram per day. This has been shown here by a real world efficacy study of glycoside modified release 60 milligram, and they moved from 30 to 120 milligram per day in easy diet study. And this study included more than 7,000 patients of type 2 diabetes, and they used this molecule as a monotherapy, or they used as a plus or add on to metformin, or switch from sulfonylureas to metformin. And what they found out that it is 1.8% decrease in mean A1C across the HbA1c spectrum, and there is 2.3% reduction in mean A1C when you are looking at the baseline of 8 to 10 HbA1c, with 46.2% and 65.3% of patients are achieving targets of less than 7% A1C at 3 months and at 6 months respectively. With severe hypos reported only in 4 patients out of these 7,000 patients. It was 0.06% reporting of severe hypos. Now, A1C decrease in Indian patient, it comes from none other than Dr. V. Mohan, that is X-RISE study. It was published in Japanese also. 679 patients with 4 months of follow-up with the use of scored and breakable once daily glycoside extended release 60 milligram tablet that enabled simple 2-step titration, that you can move from the same dose, same molecule, one dose, then one and a half dose, and 2 dose up to 120 milligram. So this is a convenience with this molecule, which is a scored, and you can use a breakable, and you can up titrate the dose very easily to achieve fasting plasma glucose of around 126 milligram and A1C of 7%. And it was shown that 8 out of 10 patients were able to achieve glycemic control of less than 7% with glycoside extended release 60 milligram. And overall reduction was 1.5% total. Similarly, same thing has been replicated by Dr. Sanjay Kalra. It was also published in JAPI. Now we have an elegant study, guide study by Shantra et al. It was published in European Journal of Clinical Investigation. 845 patients, 2 arms were there. One was having glycoside modified release, 30 to 120 milligram dose, OD dose, glimepiride 1 to 6 milligram dose was used. That molecules were used as a monotherapy, or they were used as an add-on to metformin plus or some AGIs also. It was a 27-week study, and they looked at the A1C decrease and safety regarding hypoglycemia. Both drugs Both molecules like glycoside modified release and glimepiride had similar A1C reduction. You can see here from 8.4, it came down to 7.2, and from 8.2, it came down to 7.2%. But around 50% of patients achieved A1C of less than 7%, and 25% of patients achieved A1C of less than 65%. But hypos in glycoside modified release arm was 50% lower than glimepiride. So these were the confirmed hypos, that means less than 3 millimoles per liter blood sugar levels. So they were very much less, up to the tune of 50% in comparison to your glimepiride. Also a strong evidence from advanced trial in more than 4,000 patients, and they were using glycoside modified release in intensive arm, achieving A1C of less than 1% in intensive arm at the end of the follow-up. And they started with the baseline A1C of 7.48. Now, what about the durability? So efficacy was not an issue, but only thing highlighted here that glycoside scores apart among the class of sulfonylureas, and also it is the best and better alternative to your SGLT2 inhibitors and DPP4 inhibitors when you look at the only single point of glycemic reduction. Now, what about durability? So answer also came from advanced trial. Here, the intensive arm, you can see here, around 21.3% were patients were able to maintain A1C goal of less than 6% throughout the trial period of 5 years. Similarly, 64.9% patients were able to maintain A1C of less than 6.5%, and remarkably elegant results here that 81.1% decrease patients were there who were able to maintain their A1C of less than 7%, 7 or less than 7% at the end of the trial. So now, why it is important? Durability issue is important because there is a myth that sulfonylureas, they increase beta cell apoptosis and they lead to secondary failure. But in contrast, there is evidence that in comparison to glibenclamide and also in comparison to glimepiride, glycoside has potential to protect beta cell functions, and also it can delay the development of secondary failure with sulfonylureas use. So this drug also has got evidence that it is different than other molecules of sulfonylureas class. Now, after efficacy, we look at the safety issues. And the most important issue related to safety, that is hypoglycemia. So sulfonylureas are basically, if you look at the structure of these molecules, they are basically substituted aryl sulfonylureas molecule. Whereas aryl molecule, it provides lipophilicity, lipophilic nature, and urea molecule is basically hydrophilic nature. And also this lipophilic aryl component, it accounts for the difference in sulfonylureas molecules in sulfonylureas receptor binding, its metabolism, its duration of action, and its routes of elimination. So they are all different molecules in the same class. And you can see here that glycoside doesn't have benzamido moiety at the and it binds to sulfonylureas receptor on beta cells of pancreas by freely reversible single binding. Whereas glibenclamide and glimepiride, they bind virtually irreversible and double bonding. So there is a single bonding which is freely reversible with glycoside, and there is a double bonding which is irreversible, virtually irreversible with glimepiride and glibenclamide. Also, glycoside is the only sulfonylureas which does not bind to exchange protein directly activated by cyclic AMP2, EPAC2, which is a stimulating factor, just like a push for insulin exocytosis. All these factors lead to biphasic pulsatile glucose-dependent insulin secretion, just like your DPP4 inhibitor. And it restores your early insulin peak, and insulin secretion comes back to the normal baseline level very early with glycoside use. So, and due to these inherent properties of glycoside, and it shows very remarkable efficacy in decreasing hypoglycemia. Now, regarding hypos, if you want to have evidence, It comes from glycoside use in Ramadan studies. Because Ramadan is a prolonged Muslim religious fasting for more than 1 month. And here you have two studies, Al-Sifri et al. And Arvind et al. Studies, showing that overall sulfonylureas, they have more hypos than DPP-4 inhibitors like sitagliptin. You can see from here. But if you segregate between sulfonylureas data, then glycoside has lowest hypos, even less than half with glimepiride and glibenclamide, and even equal or even less than your sitagliptin as a DPP-4 inhibitor, which has been touted, which has been always shown to you that they are our least hypoglycemia molecule causing molecule per se. Now, also from Jargar et al. Study from India, shifting from morning dose to evening dose of glycoside MR leads to least hypoglycemia and better glycemic control, and proportion of patients reporting more than one symptomatic hypoglycemic events during Ramadan was very low. It was only 2.2%. Now, if we move from efficacy, we move from safety. Also, we are moving towards the CV outcomes. Now, look at the CV safety and mortality data of glycoside versus other sulfonylureas. You know that right from the 1960 of UGDP that reported all-cause mortality increase, CVD increase, as sir has already made a point regarding that tolbutamide story. Despite that, UGDP was not a CVOT, it was not proper sense, CVOT in the proper sense, and also it was in pre-statin area. The CV safety of sulfonylureas they carry some sort of controversy regarding their CV issues, especially when you talk about ischemic preconditioning, which is a protective phenomena of cardiac myocytes for recurrent ischemic injuries. Now, this happens by opening of potassium ATP channel. Now, sulfonylureas, you know that they inherently block potassium ATP channel. They are potassium ATP closer. If you go by the sulfonylureas 1 receptor, or if you are acting at other sulfonylureas receptor like as sulfonylureas 2A and 2B, so they are going to close potassium channel, so they are going to hinder with ischemic preconditioning. Now, as glycoside is selective, highly selective for their pancreatic sulfonylureas 1 receptor, and they have got no effect on sulfonylureas 2A receptor, which is there on cardiac myocyte, and also sulfonylureas 2B receptor on vascular endothelium, and is a pure pancreatic sulfonylureas 1 receptor specific sulfonylurea. There is no hindrance with ischemic preconditioning, and there is a trial that is showing there is no issue related to nicorandil therapy, that is a drug that improves ischemic preconditioning when you use in combination with glycoside and nicorandil, and it has got lowest CV risk as shown here from Danish study that you can see here, and it included more than 1 lakh patient, and they followed for 3.3 years, and patient outcome was studied whether patient was without myocardial infarction and with previous myocardial infarction, and look at the cardiovascular death. Hazard ratio was 1.05 for glycoside, and it was 1.28 for glimepiride. And regarding those patients who are not having previous myocardial infarction, it was 0.87 hazard ratio for glycoside, and leading to decrease in around 13% cardiovascular death. And whereas there is 32% increased risk with glimepiride in patients who are having previous myocardial infarction. Also, there is no increase in all-cause mortality with glycoside, especially in patients with previous myocardial infarction. So clearly showing that this molecule has got different, you can have different properties and profile regarding CV safety. You cannot club all sulfonylureas together. There is another network meta-analysis from Simpson et al. It was published in Lancet Diabetes Endocrinology. Looking at all-cause mortality, here glimepiride has a hazard ratio of 0.83, where glycoside has got hazard ratio of 0.65. Look at the cardiovascular death, hazard ratio of 0.79, glimepiride, whereas 0.60 glycoside. So whatever meta-analysis you are having now, till now, you are always going to have somewhat better achieved targets, better safety regarding cardiovascular events and all-cause mortality with glycoside in comparison to glimepiride. Also, Zuhu et al. recent review and evidence map here. It was also published in Lancet Diabetes Endocrinology, and they looked at major adverse cardiovascular events. MACE events was 0.83 in glycoside versus 1.09 in glimepiride. Myocardial infarction, it was 0.81 versus 1.01 in comparison to glimepiride. Stroke, it was very nicely 0.84, and it was 2 times increased stroke risk with glimepiride. Also, there is a landmark study that you all know, that it is an advanced trial, which is intensive arm, showing glycoside extended release decreasing 10% composite of major macro and microvascular events. So this was the primary endpoints of composite of major, micro and major macro cardio events. So there was 10% decrease with the glycoside extended release in advanced trial. Also, there are studies which are showing that antioxidant, hemorrhagical, and fibrinolytic properties of glycoside, and all these are able, that can make you confident this drug also confers CV protection. Now, regarding renal events, renal outcomes, there is a study which was published, which was published in Diabetes Metabolism. It was more than 4,000 patients studied here. Follow-up was more than 5 years. 2 arms, glycoside and glimepiride, and they looked at the primary endpoints of ESRD incidence and doubling of serum creatinine. The results showed that in patients with preserved renal function, that means those who are having eGFR of more than 60 ml eGFR, the hazard ratio was 0.21, whereas the patient having lower, which are achieving A1C of less than 7%, hazard ratio was 0.35. These were very significant findings. Patient having age more than 62, that is elderly population, has got hazard ratio of ESRD and doubling of serum creatinine in comparison to glimepiride 0.52. That is significantly better renal outcomes than glimepiride in these subset of patients. But the best evidence comes from, again, from the advanced trial, where an advanced follow-up study also, where there was 14% decrease in microvascular complications overall. There was 21% decrease in nephro-related issues, and there was 65% decrease in ESRD risk and 20% reversal to normal albuminuria, that you can see here from albumin excretion ratio of more than 300 milligram per gram, they came back to normal albumin excretion ratio of less than 30 in 20% of your patients. Showing this, the evidence from remission to normalization. And look at this emphatic evidence from 5-year follow-up study of advanced trial. Here, that means the total study follow-up was 10 years. 5 years the trial period, then the 5 year the follow-up period. There is 46% decrease in end-stage renal disease, especially in patients without CKD. So there is a clear-cut evidence that this molecule has primary prevention part also. And those patients who have got CKD stage 1 and 2, there is 66% decrease. Now, that's why National Kidney Foundation and Kidney Disease Outcome Quality Initiative, they say that whatever may be the baseline eGFR, whether you are dealing with 46 to 60, 35 to 45, or even less than 30 ml eGFR, glycoside doesn't require any dose alteration. Whereas for glimepiride, you have to alter the dose once it goes below 60. The reason is that glimepiride has got active metabolite, which has to be excreted from kidney. So you require well-functioning kidney to avoid hypoglycemia and increasing area under the curve for the concentration. Now look at the weight. So regarding glycoside, if you look at the advanced trial, here there is the weight gain was only 0.7 kg. That means less than 0 kg. So absolutely weight neutral drug. Whereas when you are looking at VADT trial, where they are using glimepiride, glibenclamide, and glipizide, VADT had 8.1 kg weight gain in intensive arm, and ACCORD trial has got 3 plus 3.5 kg weight gain in intensive arm. So weight neutrality over 5 years has been clearly advocated from advanced trial. So summarizing, Glycoside is a sulfonylurease 1 specific sulfonylurease causing biphasic glucose dependent insulin secretion. So the drug is excellently, clearly, and very emphatically specific for sulfonylurease 1 receptor. Glycoside is at least as effective as glimepiride. Overall A1C reduction is nearly same, either as a monotherapy or in combination. But glycoside help in navigating patients safely toward glycemic goal because it decreases hyperglycemia, and also it has got very much low incidence of hypoglycemia among the other sulfonylureas as a class. Glycoside has got favorable CV outcomes and also renal outcomes, and it is a weight neutral drug. Glycoside help in glycemic control while fasting, as you have seen in Ramadan evidence, and also it does not need dose adjustment at all stages of CKD. So SU with a difference is glycoside. It has got unique mechanism of action, very, very specific to your sulfonyl 1 receptor, controlled and pulsatile insulin secretion, and it has got efficacy on par with other sulfonylureas, but it has got definite treatment durability of advanced trial is a big back at our back of this glycoside molecule. Now, low risk of hypoglycemia has been alluded to you, and CV safety has been clearly discussed here from all meta-analysis and the trials also, and also renal safety has been shown to you with glycoside, and definitely it is a weight neutral drug. So I stop here, and taking this drug as an ideal choice in type 2 management in case sulfonylureas is being considered. Thanks for the patience. Yeah.
Dr. Chandalia, sir.
Yeah, thank you, Dr. Sandeep Suri. I think we have some time left and we must have some discussion. So I invite Dr. Kant. Can I show his CV quickly? We introduce Dr. Kant and then kindly coordinate the discussion amongst us here. So Dr. Saket Kant is MD, DM, and fellow of American College of Endocrinologists. See, he's practicing in Delhi and has had many awards during his career. Best paper published in endocrine on behalf of Endocrine Society of India. See, and of course, there's a lot of other publications. So I think Dr. Saket Kant will coordinate the discussion part. So kindly take over, Dr. Kant. Any questions from your side and from the audience? Kindly,
I'll please enable slide sharing for me. Please enable slide sharing for me. Yeah. All right. So excellent talks, I guess. We have some time and some questions for discussion. So I'll probably start with Chandalia, sir. The second generation sulfonylureas, glimepiride, glycoside, and glipizide. What is your experience on the potency of all these three drugs?
They are more potent than all the other drugs that we are discussing now, like SGLT2 inhibitors, certainly DPP4 inhibitors, and it anywhere from at least it's always over 1% and can go up to 1.5% of lowering of A1C. Between these three compounds, I think they're very close. Potency-wise, they're very close. The differences are somewhere else, which we have discussed in the previous two talks. So I think, and of course, potency, A1C lowering depends upon where you start. So you always see data when it is high to start with, you always see a little more lowering. But I think it's of the order of more than 1 and up to 1.5%. And when you combine with other drugs, this is the only group which can almost come up to 1.8 or 2% lowering, which is difficult without a sulfonylurea or except insulin. You really can't bring A1C down to this magnitude. In fact, it's only sulfonylureas.
Question for Dr. Nagalur. What do you think of any specific scenarios in which you will be more comfortable using glimepiride, glycoside, or glipizide? Any differentiating features of the patient or anything else?
Yeah, it's a good question. Elderly population, where you feel that the risk of hypoglycemia is pretty high and they have poor cognitive function, where the short-acting drugs are better. So I think gliclazide is definitely better. There are studies to show that the elderly population, the extended release preparations are definitely better. The people with renal function, impaired renal function, that is also quite a good place where to use this kind of drugs, where the efficacy and safety is definitely important. And there are studies to show, the advanced study the previous speaker showed about, showed reduction of 33% of worsening of nephropathy in the advanced trial. And of course, where weight gain is also concerned, and they're also the good drug. And hypoglycemia, the early part of diabetes or later part of diabetes, the risk of hypoglycemia is pretty high. The drug with the minimum hypoglycemia would be preferred. So I think these are the situations where you would prefer this kind of sulfonylureas. And I'm personally fond of extended release sulfonylureas because this polymer matrix has the better bioavailability and no interaction with food. Therefore, they have been shown to be very effective. And if you compare the dose wise, if you compare 30 milligrams to 120 milligrams of extended release, it is equivalent to 80 to 320 milligrams of immediate release gliclazide. So that's why it's quite effective, safe. There are some instances of arthritis, backache, bronchitis have been reported with these, but very, very few, extremely few. And the hypo incidence is just 5%, and weight gain is 0.7, which is hardly any. So these are the special situations where I think gliclazide, especially modified release, will be useful.
Dr. Suri, there was some talks about the antioxidant action of gliclazide that is not there with glimepiride. That was probably not touched in any of the slides.
Yeah.
So do you think it is an additional role that gliclazide may have, the
Yeah.
antioxidant action?
Yes, there are many mechanistic studies, and similarly, even with glimepiride also, even with gliclazide, glimepiride, both they have got different certain mechanistic studies, and also certain lab data is there. They do have antiplatelet action, they do have antioxidant action. So in a way, you can say that these mechanistic study, they also give you that the endpoints which are achieving, we are getting, like CV safety, hypoglycemia decrease, and also improved durability as per the beta cell apoptosis is considered. And these mechanistic data, they are just like they are under the carpet, these type of things which are not evident clinically, but you are looking at the results, so they definitely support the results which we are getting in the control trials.
So, Dr. Chandalia, a wonderful molecule. I've been using it a lot. Probably you have used it at least five times more than what I have used. But by no data after advance, and advanced data has only with the modified release. It is not there with the immediate release. So what comments do you have for that? Why no data after advance, and why only modified release, no the data with the immediate release formulations?
I think when the advance was started, the modified release had probably come in somewhere at that time. And they wanted to evaluate that. So I think that was introduced. But some of us who are practicing for a long time may use the immediate active form. Of course, no more studies have been done, but there have been meta-analysis showing, those cardiovascular differences in the cardiovascular outcomes. And there, I think it definitely excels over all drugs, In fact, it starts coming closer to some of the other drugs like SGLT2 inhibitors. You see, the 3-point MACE is about 10%, SGLT2 inhibitor about 16, 15, 18%, 3-point MACE, and many other situations there is benefit. There can be studies launched, but what has happened is these are some of the very economical molecules. And frankly, I don't know whether a very expensive study or real cardiovascular outcome study can be launched. I still like to use the quick acting when I'm trying to control prandial sugar. Therefore, I would really like to ask Vijay Niglu whether they have done the studies, any studies where they really shown the prandial effect is similar. Because I find prandial effect is so good that 20 to 40 milligram TDS with metformin See, prandial control of sugar is very good. And to my mind, logistically, hypo will be less with quick acting one compared to other. So in these two, is there any data you can look minutely the differences between the two? Because I'm still using extensively the short acting, in the divided form, and very rarely, very mild effect I want after exhibiting a DPP-4 SGLT2, then a 30 milligram of extended. But 60 milligram, 60 twice a day extended, I don't know. I have still not come to that stage, where I would do that. See, but there are a lot of data showing that they work. And once I had a patient from Paris who was treating in Mumbai, and during COVID he got stuck there, and I had 3 doses of insulin not controlled. So what do I add? So metformin was already there. So I wanted to add short acting, glycoside 3 times a day. And he immediately sent me an email that it's a French product, of course, from Servier, but short acting have been discontinued in Europe. Only available is the long acting. See, then I told him, go ahead and take that. He got a good effect with that also. But I was hesitant because I'm only used to, see, we say, as Goodman Gilman said, use the molecules which you have familiar to you, which you know thoroughly. So I use that. So this is the situation. Many countries, they discontinued short acting. By I realize that. Yeah.
Yeah.
So I think, Vijay, would you like to comment on pharmacodynamic and kinetics between these two? Because the molecule is great compared to any other sulfonylurea, and definitely comes very close to other molecules, in its beneficial effect. So this part I'm not very clear, because in India we continue to use more.
I think about the kinetics, there's a difference. About dynamics, there's a safety. In the kinetic wise, I feel that once a day therapy is quite effective in controlling the sugar. So it becomes convenience and adherence is important, where that is so far as the adherence is concerned. In the dynamics, I feel the side effect profile is far less. The risk of hypoglycemia is definitely less. Of course, there is no study which looked at both molecules head to head, whether the glycoside immediate release versus the extended release made any difference. Even the great study has included glimepiride, not glycoside.
Yeah.
So there is no evidence to say so far. But I think clinical evidence that we have been using, I think the risk of hypoglycemia is a major concern, and especially during Ramadan and some kinds of fasting. I feel so far as the pharmacodynamic properties are concerned, the safety of hypoglycemia and weight gain is far less. Otherwise, I would not know about the postprandial control of sugar, where I agree with you that immediate release would be definitely better to control the. I agree. That's point well taken.
So taking this discussion forward, Dr. Negalu, the difference between glycoside MR versus plain, the highest dose of MR formulation would be 120 milligram, whereas of the other
320.
formulation, the
320.
320, 320 is for the plain formulation. For
Yes.
the
120
formulation is 120. 120. So the modified release formulation, once a day would suffice. So
Yes.
we never had a 120 milligram formulation. We still have the 60 milligram formulation
Right.
that we give twice a day. So do you think 120 milligram would do much better than 60 milligram dose in terms of nocturnal
I think,
hypoglycemia, for example?
yeah, probably I think the weight of the patient that we have been treating here, I think 60 is sufficient to treat these patients of diabetes. 120 probably for a heavier patient, maybe in the Western country they're using it, but personally it's not available here. I've not used it, I don't know. I have no experience at all. But if you compare the efficacy of compare the dose to dose strength wise, that 30 120 is equivalent to 80 and 320 almost in terms of the efficacy wise. And safety wise, you have all the safety parameters with you, no hypoglycemia, no weight gain. So I feel, I think it's efficacy wise 60 is sufficient for our patient to control sugar.
So coming to Dr. Suri, ischemic preconditioning, which one of these you think is the best? And there's one question in the chat box. So what would be your sulfonylurea of choice in patients with CVD?
It's a glycoside.
So glimepiride and gliclazide do not abolish ischemic preconditioning. Glibenclamide does.
So for
Ischemic
glimepiride,
conditioning,
let's
I think
take
it's more of an animal experiment. It's
so,
not in the human being.
yeah,
The ischemic preconditioning, they only studied in the rats,
yeah,
and they found out that the response to ischemia is definitely not lost, in patients who are receiving this kind of molecule, who Dr. Suri mentioned about
yeah,
benzamido
yeah,
receptors in the
yeah,
myocardium, and this is not affecting that. Therefore, the ATP sensitive
yeah.
channels are not closed.
Yes, sir.
That's how the calcium doesn't come into the myocardium, and
Yeah.
therefore there is no contraction, therefore no oxygen demand.
Yeah.
But this is purely experimental in the lower animals. There is no human data at all,
Yeah, yeah,
and we have no evidence to say that this exists in human beings.
yeah. One thing I want to add here, that glimepiride, we know that glimepiride has, acts also at sulfonylurease 2A receptor at the myocardium. Now there is a two issue. One is at the myocardium, and another, these receptors are also there at the level of
Vessels.
mitochondria. Mitochondria. So it is seen in their experimental data that glimepiride blocks the myocyte level, but doesn't touch at the level of mitochondria. So they are saying that, and result was that probably glimepiride is also not touching the ischemic preconditioning part. This is experimental data.
Yeah, that is what the question was about, because glibenclamide surely abolishes ischemic preconditioning. Glimepiride, gliclazide do not abolish ischemic preconditioning. So it was in one of the slides, it was there, sulfonylureas in the heart, all-cause CV mortality reduction was there with both salt sulfonylureas. But if you look closely at the data with the patients who did not have an MI, ripaglinide was far, far, far more superior in reducing CV death as compared to gliclazide. But within previous MI, only gliclazide was reducing CV death, and ripaglinide crossed over. So any explanation offered for that? Because it's a superiority for ripaglinide with no myocardial infarction, and crossover to the other side with ripaglinide in a patient with previous MI.
I don't think.
So we cannot have that.
I have no evidence. It's only short acting. That's the only advantage. So therefore, the hypoglycemia, I think what we must remember is that hypoglycemia is the acquired cause of prolongation of QT interval.
Yeah.
And hypoglycemia is also cause of inflammatory response. And there's evidence now to say that the repeated episodes of hypoglycemia can also be atherogenic. And there are patients who develop acute infarct with the episodes of hypoglycemia. So prolongation of QT interval, and if you have a drug which again adds to QT interval, for example, you have a drug like DPPO inhibitors, teneligliptin, for example, which prolongs QT interval, and there's a hypoglycemia, patient with renal failure. All these possible combination or coexistent comorbid condition can induce the risk of myocardial infarction pretty higher. I think the hypoglycemia short acting is the only answer, but I don't have any answer, and I don't personally use it much as well, except in patients who have a compromised renal function.
Probably hypoglycemia also leads to a prothrombotic state also.
That's what I said. That's what I said. There are, of course, there are experimental data saying that the hypoglycemia is also atherogenic, and there are patients of acute myocardial infarctions because of repeated episodes of hypoglycemia.
Dr. Chandalia, what about your experience with sulfonylureas and the kidney? Because the guidelines, KDIGO guidelines, basically suggest you can give it gliclazide at very low eGFRs also. But if you look at the Canadian guidelines, they say that less than 40, be careful with even gliclazide. And ripaglinide, for example, with no renal excretion and the benefits that were shown in that study, no MI, renal disease, most patients with renal disease dying on MI. Would you prefer to give ripaglinide or gliclazide to someone who's got an eGFR of 30?
Yeah, I think I must say that the maximum hypoglycemia currently I see is people with renal compromise and taking glimepiride. The maximum cause of hypoglycemia, insulin and glimepiride, frankly. The gliclazide will cause much less, but what I use in my patients with renal compromise is only ripaglinide. See, I'll use a DPP4 inhibitor like you see linagliptin. Yeah, and then not control. Of course, insulin is there, but sometimes this doesn't suffice. People with very bad renal failure, sugar start coming down. But there is a phase where sugars are very difficult to control. So there you're given insulin 3 times a day, you exhibit a linagliptin 5 milligram once a day, you still have a problem. I had ribaglenite. I'm still using ribaglenite regularly, but very small doses, zero point 0.5 milligram 3 times a day. Not what the books say, 4 milligram 3 times a day. I've not written one prescription in 30 years or so that ribaglenite is introduced. See, so those doses described in books are, I don't know, they are not for normal human Indians, at least, not Indians. The other people are also normal human beings, but they're really abnormal in their weight and many other aspects, I must say. See, so I think 0.5, 1 milligram 3 times a day of ripaglinide. See, I haven't had much trouble with that. And both of these together give you such a good effect with insulin therapy. And otherwise, we get tremendous variation and up and down. When you introduce drugs like this, you get a very smooth response. See, so I think the glycoside I have not used with renal. I have not prescribed. Glimepiride I have not prescribed ever. My prescription are very few. All these hypos I see, but in some of the acid patient landing with hypo, I realize it was glimepiride.
So,
Although
Dr.
there is
Nagel,
a study showing it doesn't cause hypo, by the way. So remember that I want everybody to know that one careful study can be produced and safety can be shown in a given set of circumstances of any drug. That doesn't make it it's an experienced clinicians should have. They should not use it.
what about Dr. Nagalur and Dr. Suri? Would you be comfortable using gliclazide at an eGFR of 30 or even less than 30?
I think 30 or less than 30 is quite okay because again, as sir was saying that this hypoglycemia is pretty common in patients with kidney failure. There are both ends of the spectrum in patients of renal failure. Either you can get hypoglycemia, very difficult to control diabetes, especially when they're acidotic. And the hypoglycemia normally initial part of diabetes because the kidney also takes part in the gluconeogenesis. 30% of the glucose production comes from the kidney, and the source of this glucose production is glutamate, which comes from the muscle. So glutamate coming from the muscle, the kidney synthesizes glucose, and therefore when that effect goes off, the hypoglycemia sets in. And of course, the insulin clearance is also poor, and therefore the insulin sticks on for a longer time and the patient gets into hypoglycemia. This is the early part. When the patient becomes acidotic, then the sugars go haywire. And that's a time it's very difficult to control diabetes. And there you might have to use 3 doses of short-acting insulin and maybe glipizide or even gliclazide 30 milligrams extended release could be okay because the hypoglycemia is quite less. And the advanced trial has shown that there's a reduction by 33% of worsening of nephropathy in the diabetic patient. So there is evidence to show that the modified release definitely works in patients with renal failure. But of course, the caution is always there. The hypoglycemia has to be kept in mind. And that's a red herring in patients with a renal impairment.
Sir, thank you very much, the entire faculty. Dr. Chandalia, sir, I would request you to deliver the concluding comments for the day.
I won't take much time on that because I think we have discussed most of the important issues we have touched upon and highlighted. I would say that this molecule and its qualities have not been very well appreciated. I think this molecule needs a wider use because cost-wise, these are very cost-effective. These sulfonylureas are most cost-effective treatment, metformin and sulfonylureas. And although we have sometimes in practicing in urban areas, a sort of impression that these drugs are out of date and they should not be used, and such comments sometimes we hear from a Westerner. But the services, public health services of these countries still give metformin and sulfonylureas. You see, so all that costly things are probably for export, I think. You see, indigenously they use also same kind of treatment. Especially National Health Service in UK uses sulfonylurea and glibenclamide. I've seen metformin is the glibenclamide. You see, I thought that they should actually graduate to glycoside. You see, but so please don't fish away sulfonylureas. They are very effective drugs, and this one is particularly safer for the angle of hypo and and pretty good in efficacy, and even some cardiovascular and renal protection data. So I think this should be used a lot more than what we are doing, really. I'm really amazed that how industry can, prevail on the medical profession to use one drug over the other, like glimepiride, for very wider use. I sometimes known to change something like 10 or 15 prescriptions a week from glimepiride to glycoside. See, because I don't find great sensitizing effect also, and hyper because it's very long acting. So the person doesn't eat properly, goes into hypo, and the post meal it doesn't work very well. So that's why I really find that my choice is truly this glycoside.
Thank you,
This
sir.
is what I've been using. Yeah.
Thank you, sir.
Priceless drug, priceless.
Yeah, really
Priceless.
great.
So it's priceless drug.
Yes, sir. So after a series of wonderful lectures and a very insightful panel discussion, Dr. Chandalya sir has aptly summarized today's scientific discourse. Now I request Mr. Pawan from the commercial team to deliver the vote of thanks.
Yes, thank you so much, Dr. Nareen. At the outset, let me thank